Thank you for being here right at the end of the conference, but also for your presence throughout and all your contributions, both in papers and discussions. I've had a wonderful time at this conference. I hope you have too. I've got two brief announcements before I hand over to Rose to give our closing plenary. The first, very quickly, is that the committee is looking to co-opt some early career researchers, PhD students, to assist in bringing together events specifically aimed at that group. We've mentioned this a few times through the conference, but if, in case you haven't heard and you'd be interested, please just contact a member of the committee if you'd like to talk about that kind of role. We hope very much that those events will happen at our next annual conference, which will be in Leicester next September. And we hope to see you there, and perhaps also at the main BSA conference, which is in Leeds this year, with the theme Sociology in the Age of Austerity. And there will be a medical sociology stream and a number of special medical sociology events within that conference. So there'll be, stuff going on there in April. You don't have to wait till next September. Both minor points immediately remind us of some of the special things about Rose within the MedSoc community. And she'll need very little introduction to many of you. She has a special place for us, not only for her dancing abilities, but also for her loyal following of PhD students and grateful people who've been through her methodological training over many years, and also as the current convener of the BSA conference. So Rose is a wonderful citizen for the community, and I'm very glad today to have the chance to hear her talk about work for a change. And also as the proofreader of the programme, impatient to understand and get to grips with the new term that kept tripping us up in her title, which is the biographical turn and the socialization, with an O, of medicine. Thank you, Rose.
Thank you. Thank you, Catherine, and thank you very much for the invitation to give this closing plenary, which I'm absolutely thrilled about. I was going to start with an apology for having a title that turned out to be a proofreading nightmare. But what I wanted to really distinguish, I suppose, between make sure that it wasn't confused with socialisation. I'm actually doing a bit of a biographical turn of my own today, in that I'm revisiting work that I did for my own PhD, which was a study in the late 70s of professional socialisation for social work. I should just warn you as well, if you do access the slides online, there won't be any pictures on them. They'll all be removed because I don't actually have any, don't have copyright permission for any of them, so they'll look a bit duller. I just wanted to start by revisiting, I suppose, and rethinking sociology of the professions. I've got up here Elliot Friedson's seminal book on professional dominance, which is very much, I think, shaped the way that medical sociologists think about the medical profession, and that's Elliot Friedson down there. Of course, he's not the only person who wrote about sociology of the profession. There are also people like Everett Hughes, also in the States. And what I'm trying to do here is just kind of distill some of the main points about how we think about sociology, the professions. That a profession was defined by having a distinctive and complex body of knowledge, selectivity with regard to admission, lengthy training, concentration on boundary disputes really within medicine, because it was seen really as the quintessential profession. And that it very much was seen as occupying a privileged position with regard to the semi-professions, of which, of course, social work was one. And I think the debates in the late 70s were about whether the semi-professions were actually ever going to be able to aspire to full professional status. I think it's really rather changed, and what I'm going to try and argue really is that I think medicine has changed and sociology has changed, and it's moved much more, I think, towards some of the sort of claims that the semi-professions traditionally made, whilst still making appeals to all of these traditional claims at the same time. I wanted to just briefly revisit the medicalisation critique as well, which will be very familiar to everyone. Technical gaze, episodic focus, mechanistic rather than holistic approach, and concentrating on the physical rather than the psychosocial. But I do think that the balance has been, to some extent, redressed, which doesn't mean that medicalisation doesn't still rear its head, but I think largely as a response to particularly feminist critiques of maternity services, medicine really has had to sit up and take notice, and there's been a lot of changes. We've seen, I think, the ascendance of choice and agency, which is not without its problems, as I'm hoping to go on to explore, and what I've called the biographical turn. And I guess what I'm trying to get at here is really the idea that medicine is embracing what are essentially sociological ideas. Nicholas Rose has talked about what he calls size-shaped spaces, and he's talked really about the kind of prevalence of armchair psychologists. But I think a lot of sociological ideas have permeated through to society in general and also to the medical profession, but they're not always really labelled as such or recognised. Medicine has changed, of course, against the changing backdrop of society itself and shifting cultural preoccupations. And we really have seen, I think, the ascendance of biography. Simon Williams, rather mischievously, I suppose, talked about Mike Berry's notion of biographical disruption and actually reversed this and actually argued that it was the biographical disruption that maybe we should be seeing as the chronic illness, because biography occupied such a privileged position. Biography is ubiquitous. All sorts of people are kind of getting in on the act. The title there, it's a bit blurred, but is You Only Live Once, or in her case, perhaps twice or even 3 times. And as she's still relatively young, I think we can confidently expect some more contributions. It's a frivolous point to a degree, but I think that the advertising agencies are particularly adept at capturing the zeitgeist. And this was a very well-known and debated advert for John Lewis, which really took this biographical focus and had, I think, a Guillemet's cover of a Billy Joel song, and it was aired, I think, during a Coronation Street break on a Friday night, and by the middle of the next week had 120,000 hits on YouTube. It really seemed to touch a nerve, and there was all these column inches and the newspapers devoted to it. The chattering classes were blogging away, getting terribly exercised about the way that women were portrayed and, getting really het up. And I think actually forgetting along the way that it was only an advert. But we do find biography, or ideas about biography, permeating, in particular, health promotion. And this is a study that I've recently worked on with colleagues in Dundee, looking at what was called the suboptimal uptake of folic acid. And being recommended for all women who might become pregnant. So it's really extending the gaze backwards to preconception, and this idea that you know when you're going to get pregnant, which is a nice idea, but it doesn't quite work out that way. But of course, the woman that we talked to in this study, it was a focus group study, they had a much more nuanced understanding of biography, and as well as looking forward to this imagined pregnancy in the few cases where it was indeed a planned pregnancy, which is a problematic concept in itself. They also looked, they actually looked back. And this is a woman talking about how she'd taken folic acid during her first pregnancy, and she didn't, near the end. And she was worried that, she'd given her first child a better start in life. And so she's looking at the much longer term, kind of the family and issues about equity between siblings. There's another study that I was involved in looking at couples' experiences of attending a fertility clinic. And what they were doing as well, they were also looking back as well as looking forward, castigating past selves, really, in this case for not trying to get pregnant earlier, having delayed it, having left it too long in their view. The fascinating thing I thought was that they're kind of between a rock and a hard place with this, because they're also castigating future selves and thinking about how they will view themselves in the future if they don't pursue all of the options at their disposal today. And I think that is a much more nuanced understanding of biography, and that it begins to highlight, I think, some of the ways in which it is quite a problematic concept and quite a difficult concept to get a hold of, and particularly to try and operationalise in a medical setting. I want to talk quite a bit about the work around maternity services, fertility services, largely because that's an area where I myself have done quite a lot of work. And I do think the pendulum has swung quite far the other way, and perhaps a bit too far towards the kind of sociological end of the spectrum, or this kind of socialisation of maternity services. This thing about the involvement in decision-making. I mean, it's all kind of motherhood and apple pie stuff, but this focus on pregnancy and birth as social phenomena, which all sounds wonderful, but is not without its problems. Focus on the couple, particularly, which is something I want to come back to. And what I would argue is almost the reification of choice. But the exercise of choice, of course, is really quite a different matter. And although the medical profession has been responsive, I would argue that it's sometimes only been in relation to quite a vocal minority. And there are right choices and there are wrong choices. And particularly there's a social class dimension. I think Margaret Nelson, back in the early 80s, did some very interesting work in the States, looking at working class women and their expectations about delivery. And what they said basically was they wanted all the pain-killing drugs that were available, thank you very much. And that's not really a voice that we heard very much, or a view that maternity services seem to respond to. It's also, I think, problematic to what extent it's possible to exercise choice in this area, and also, I suspect, in many others. Potential for complications, life intervenes, basically, and there can be quite a mismatch between expectations and unfolding events. And I think to present the promise of choice can in itself, further down the line, lead to difficulties and disappointment. Also, in relation to conception, reproductive health, this illusion of planning. Conception, when you think about it, is actually a relatively rare event, and it's much easier to prevent getting pregnant than it is to ensure that a pregnancy will occur, and this possibility of falling pregnant naturally anyway, despite all of the interventions. So it's certainly not an exact science by any means. And certainly in terms of planning, when we did the interviews, focus groups for the various studies, it was not at all uncommon to have someone tell us, well, I wasn't trying to get pregnant, but there again, I wasn't really trying not to. So that this idea that people kind of plan their lives out is maybe a nice marketing device, but it doesn't hold an awful lot of water, really. Thinking about fertility clinics too, I think that this really over-socialised perception of reproduction, that you can exercise choice, you can plan. And fertility clinics, particularly, very much focus on the couple as a unit, which has a nice warm ring to it, and sounds as though they're actually taking notice, because of course it is an issue that very much affects the couple as a unit in social terms. But really whether that's so appropriate in the medical arena, I think, is another question. Fertility clinics are, first and foremost, I think, delivering a product. Most of them have some non-NHS service users. There's really quite a strong pro-natalist strand. Muted discussion, I think, of other options. And this is a notice board in a fertility clinic, and it's a pretty typical one, really, full of photographs of happy couples and babies, and not really any photos of happy couples without babies, which is actually a more common outcome than the happy couples with the babies. I think it's also problematic as to whether a couple can have a biography, given that very often only one of the couple actually has a fertility problem, and it's an issue as to whether they're actually going to stay together. And I think it's bowing really to social construction of the couple, rather than being fully attentive to what are, after all, clinical issues. Couples themselves, I think, have difficulties with this concept of biography and struggle with it a bit, and particularly ambivalent with regard to counselling. And this is what I've argued is a lay version of biographical disruption, really. And this is couples attending a fertility clinic at pains to insist that they are not like this couple, who are defined by this and can't really think of anything else. So I think what the couples really were challenging what they saw as a dominant social construction. Whether that was accurate or not is another matter. This is another study with young adults with cancer, and we were interviewing them about their concerns about future fertility. What it did, of course, was accelerate decision-making as a couple. Sometimes they were a very new couple, and then they were having to discuss all of these issues about their reproductive wishes. An emphasis on the ethical dimension too, particularly for young men who had the option, at least in theory, of storing sperm for later use. They actually were faced with a tortuous set of forums and all sorts of discussion about who could use the sperm and in what conditions, which is fine, but I don't know that it's all that appropriate in terms of whether our medics strain beyond their area of competence in discussing some of these issues, and would a more episodic approach actually be best after all? So to store the sperm and then debate all of these admittedly difficult ethical issues later on. I argued really that medicine is at least nodding to or embracing to a degree a new cultural repertoire, embracing of narratives. There was a time where you couldn't pick up the BMJ without there being at least 2 articles and some aspect of narrative. Privileging really of first-person accounts, which is fine, but they tend to be descriptive, they tend to be condition-specific accounts, they tend to be uncritical, and I think lead to an analytically impoverished understanding. Paul Atkinson, in particular, has warned about the dangers of romanticising our respondents' accounts. And I think that it's not just in clinical practice. I have been, I suppose, puzzled and a bit exercised by the emergence or, rise of the medical humanities. And I think certainly some aspects of that are quite problematic in that they rely very much on an uncritical adoption of some of these almost misery memoirs. And not just misery memoirs, but this idea that the medical humanities see themselves as not just being concerned with ethics, but focusing on medicine as a human practice. And I think that's a very interesting term. Going back to Nicholas Rose's Governing the Soul and his ideas about psi spaces, he talked about transformative stories. And I think that's very much the case. Some of these accounts of chronic illness as well. But the recovery narratives, I think, are very interesting because, again, there's this sort of reversal that the event itself is re-evaluated in terms of its capacity to illuminate biography. So it really is not so important anymore. And many of these accounts embrace, even celebrate the misfortune that's being recounted. And people frequently say they wouldn't change what had happened to them because they have grown as a person, they have learned, whatever. That is kind of dominant narrative. The injunction to be positive. I don't know how much potential for resistance there actually is here. But I've come across an account of a journalist who very much took issue with this injunction to be positive in relation to cancer. The baby boomers, I think, in terms of possibly a challenge. The baby boomers have come of age. This, I think, is the portrait in all our attics. And I think that the French have a lovely term for baby boomers who've come of age. They call it le papy boom. But really the idea being that just through sheer force of numbers and purchasing power, that this group of people really have a lot of power. They're often valorised as having redefined every life course stage as these are encountered. Often, it has to be said, valorised by baby boomers themselves. Certainly, we have of late seen commercialisation of ageing, I think, in these are customised walking sticks, which is a subject close to my heart because I almost had to take one to this conference. This is actually very much, this is an American website where grey power is a big thing. And one option you can have is this rather fetching cowboy cane. But it is, I think it's interesting. It's well, I think it's an investment opportunity where the smart money might be if I had any to invest. This is a quote from Huber and Skidmore, who wrote this book that rejoices in the wonderful title of Why the Baby Boomers Won't Be Pensioned Off. So it's a bit kind of defiant. And I'll just because we're kind of having to move on, I'll try and not spend too much time on it, but this idea that they really are a force to be reckoned with, that they can effect change, and potential to define political consciousness for a new generation, no less. I think certainly there is a potential for a dialogue that might be similar to the dialogue that happened in relation to maternity services as this group of people age, in terms of supply and demand. This is my favourite Biff cartoon, and it's a bit blurred, so I'll read it out. The nurse who's wheeling this old guy in the nursing home is saying, "Come on, Ben, it's time for your Van Morrison," which is definitely my favourite Biff. I think it suggests, the potential of personalised services, of, making demands for something better, something different, something more appropriate. I've long been trying to persuade the BSA that we need to set up a retirement home for medical sociologists. I see it as a kind of perpetual conference, and, I suppose we'd all give the same papers, but hell, That's right. But I think it might be overstated a bit, the potential of this group. I think it'd be really interesting to see what does actually happen. I think there's a lack of commonality of interests and concerns. There's not the kind of rallying cry that maternity services provided for women of reproductive age. There's a distinction between early and late bloomers. Do they have different needs, different concerns? And obviously social class differences too, as Phillipson and colleagues pointed out in a recent SRO paper. But certainly potential for biographical anticipation, the extended reach of health promotion. My colleague Carol Komaromi, who many of you will know, who does work on death and dying, said to me recently, well, you can't relax, you don't need to worry about reproduction, because actually we're being instructed on how to prevent Alzheimer's, so it just really moves into another phase of life. Issues to do with palliative care, living wills, advanced directives, again, kind of birth and death, and raising difficult ethical issues. Potential also, we're all being induced to have funeral plans, and indeed we can have a customised service should we so desire. So really the reach has gone from preconception, like the folic acid stuff, to potentially beyond the grave and having a stake, in what happens after you're dead. But does this really translate through? I think medicine's biographical turn is potentially problematic, and ultimately it's an impoverished version of sociologically derived insights. It can be detrimental for service users, as we've seen, can standardise, reify biography. Whose biography anyway? Because biography is a very individual concept. Can you really have a social focus? It's a partial view. It emphasises certain life course trajectories at the expense of others. It's oversimplistic, heavy reliance, I think, on staged accounts, particularly in relation to chronic illness, because they're just very persuasive, I suppose. Oh, and an inability, I think, to treat biographies as unfolding and contingent. Medicine, I want to argue, has made some claims to authenticity and legitimacy, and we appear to have lost a slide here somewhere. I don't know what's happened to this slide. It's gone into the ether. But what I was trying to argue was that medicine's making new claims, and perhaps actually old claims, and that alongside this idea of the expert patient, which is very much a response to sociological critiques, we've actually got what I've called the human doctor. And it's not really a new thing when you think of medicine's origins and, you know, talking about the humours and its closeness to moral philosophy, really kind of way back. But I think it's involved doctors in making different sorts of claims to legitimacy and authenticity. Which takes me back to my own PhD, where I talked about what I call transsituational demands that people in the semi-professions had to make about what sort of person they were, what sort of values they had, demonstrating they were a proper person. We've seen individualised accommodations to ethics and values, particularly thinking of some work I did on with a colleague on terminations and staff's responses, so that some would do a medical termination but not surgical termination. They would do it up to certain gestation and not beyond. Some would insert a prostaglandin pessary, but they wouldn't do anything. They wouldn't kind of deal with what happened afterwards. Individualised accommodation to ethics and values. And there's been some suggestions in some of the papers at this conference, I think, of doctors engaging in those sorts of practices. It's a pity I've lost this slide. I don't know where it's gone into the ether, but the other thing that I had at the bottom of that was that I think there's a potential to explore the relationship between structure and agency. And when I think when we've tried to understand what's happening in the medical profession, we've very much privileged structural explanations. And when we have looked at agency, we've very much privileged patients. And I think there's quite a fertile ground for research in exploring the agency of individual medical practitioners and how that's achieved and negotiated. My conclusions now, that I think we need to stop being thrilled every time somebody invokes a sociological idea. I think we often are, because we kind of feel we're unappreciated and nobody understands, really. We need to retain a critical stance. I think it's important to review our own role, because a lot of us are involved in teaching medics, and think about our publishing activities. I was interested that Alan Peterson talked about, you know, the funding climate, and these are not easy issues. We've got to publish. Often we have to publish in health service research type journals, especially with interdisciplinary research, and I think it does lead to these pared down and rather simplistic accounts. It's important also to explore possibilities of engaging with the public via non-traditional media. I think also as researchers, encouraging our respondents to problematise alongside researchers. I'm not going quite as far as Alain Touraine, who, like French sociologist, who uses focus groups to get people to develop sociological theory. I don't know how realistic or even desirable that is, but I do think we could go a bit further and just not passively collect accounts, but actually get more actively involved in co-construction of new discourses. And then I think we might begin to contribute to what Nicholas Rose has called organised resistance.